4. Our topic is the questions no one wants to ask, but everyone wants to know. So this is kind of one of those mutual conversations that we're going to have where we have some predetermined questions that we think people would want to know, but then there's going to be a pretty significant amount of time where I'm going to open the floor. So a lot of it for Q&A. So this is kind of a free for all, right?
Thanks so much. Yes, I'm Dr. Chaconas with Memory Movement going on my 10th year. So Chris, who's with us today, and myself, we're like the legacy people, but we're just delighted to be here today to help answer questions. And I hope we have an enjoyable hour together.
Perfect. Chris, you want to go ahead and introduce?
Sure. Yeah, I'm Chris Ryskiewich. I'm one of the nurses here. I've been here since a year after the clinic opened, so I've been here over 11 years almost. And I'm just so grateful that you all have taken the time out of your day to join us. I hope that we can have a collaborative hour where we can also, we're not just going to be telling you our little tips and tricks, but hopefully you can share with each other because that's important. So thank you so much and hope you get some good nuggets out of this. Thank you.
And then last but not least, we have one of our newest additions to the team, Tom. So if you would introduce yourself.
Hi, everybody. My name's Tom. I have only been at Memory Movement for a little over 2 months, but I'm very pleased to be here. I have a behavioral health background, did a behavioral health fellowship, and just very grateful to be part of the Memory Movement team. So thanks so much for including me today.
2 months versus 11 years.
You know,
I mean, what's the difference?
11 years.
It's like he's been here 11 years already.
What's the difference? Right. Okay. Well, without further ado, I think, Chris, you wanted to get us started.
Indeed, we had several questions surrounding personal care, so bathing and hygiene, and just how do we manage that when we're getting resistance? How do we protect our loved one's dignity? So this is, first of all, a very common, can be a common problem. For some reason, a lot of our patients become very resistant. It might be that they feel vulnerable and it's uncomfortable for them. And also sometimes they really think that they just took a bath or a shower and there's no need to do it again. So for a variety of reasons. And it's also one of the hardest things, hands-on caregiving, that a lot of our care partners are required to do. So I think the very first thing is to kind of be in touch with your own feelings about this. If it's something that you really dread doing, if it's something that you really don't have time for and you're hoping to get it done really quickly, all of those things can affect sort of the outcome. And I will say, we're gonna talk about several things that might be helpful. I don't want you to feel like you failed if none of these things have worked and you've tried them all already. And sometimes it's just a time when we have to bring in some outside help. Oftentimes our patients will do things for others outside the family, outside their loved ones, so that sometimes is the answer. So just wanted to preface that. I don't want anyone to feel like they fail. And also know that what works on one day might not necessarily work the next day. So just to keep that in mind.
Yeah.
And also, if you are going to, engage in this, it's time for a bath today. The best you can do to kind of calm yourself. So take a few deep breaths, get prepared, get the bathroom warmed up, get all of your things together, get the water running at the right temperature. And then your approach, if you're standing over your husband or your mother, whoever it is, and you say, okay, it's time for a bath or a shower. We got 20 minutes. Let's get going. Come on. It's probably not going to be well received. So if you can, in a very calm way, sort of get at eye level, and say, guess what today is? They might not even like the language bath or shower. So you could use alternative language like it's spa day or it's time to freshen up. I saw that somebody had devised these little reminder cards, really beautiful cards whatever that person might like, flowers or whatever. It says, oh, here's a reminder. Today is the spa day, or something like that. So some incentive, provide a little incentive. And it might be just, our little routine, like post shower routine, we get ice cream, or if it's depending on the time of the day too, can make a difference. So your loved one, might be better in the mornings, and it might be go downhill from there. So maybe you don't want to do that in the evening when they're tired and more resistant. So kind of find the right time. Mm-hmm. And maybe it's, you look so great. You look like $1 million. Let's go out and celebrate and get some lunch. Just a little incentive. I did see one person say that the only incentive that their loved one responded to was a $20 bill. So that could get expensive.
I'd respond too.
So you kind of have to check your to-do list and just put that aside and just know that this is probably going to take much longer than you would like. But hopefully with a little gentle coaxing can get it done. So having some things in the shower ready, a grab bar that's secure because you're going to try to be there to help, prevent a fall, and have something that they can feel secure and hold on to. A shower chair. Some are made that they fit entirely inside of a walk-in shower. Other chairs are sort of like two legs are outside. It's like if your shower's over a tub and the other two legs are inside, so they can sit down and then just swing their legs over, as opposed to stepping over and getting in and out of a tub. A handheld shower head is usually a little bit helpful because you can direct it and it's not such a heady stream. You can adjust, how strong a water flow is. And you do need to make sure you can adjust the temperature of the water. That's one thing that a lot of folks have trouble with. And you can't just say, sometimes it might be that you can't say, they're perfectly capable, but maybe they need you to set that temperature, and then maybe that's all they need. So it's really just a matter of kind of realizing where they are and what they need. And maybe they just need somebody on standby who's just right outside. They have their privacy. You're just right there to sort of help them get in and out and that kind of thing. So, and sometimes they need a lot more than that. But kind of having everything together if they do need more help. So you have, your shampoo, your soaps, your towels, the clothes they're going to wear when they get out. You've warmed the room up. If you have a heat lamp or a space heater or something like that might be helpful. So you can always let them do what they're able to do. And you can ask. And you can start by, let's just get in the bathroom. It's so nice in here. I've got a brand new, your favorite lotion ready, and whatever it is that might make it more pleasant. Having some music on, maybe a candle, something like that. But just kind of talking and distracting. So if there's music on, maybe you start singing along. If there's, you might just get them in there and say, you know what, let's start by taking off your shoes. And do you need some help? And you just kind of start with that. And before you know it, they're kind of ready for to get into the shower or the bath. To provide some privacy, you can take a towel, lay one over their lap. If it's a female, you can put it over their shoulders. And so you can leave that on. They can get that wet. Eventually they might want it off, but they can take a washcloth and wash underneath. So that's one way you can kind of maintain their dignity and their privacy a little bit.
That's good.
Mm-hmm.
I would say I know hygiene is such a big topic for a lot of people. And so, Tom, Dr. Chaconas, did you have anything to add to the plethora of great information that Chris just gave us?
Go ahead, Tom.
Thanks. I had a few things. Number one, I would say that depending on the circumstances, not every day has to be bath day. Right. Not every day has to be shower day. If you can get by with the once or twice a week for a full bath and full shower rule, if that works for your family, that is fine. If you can get the bath towels, like the towel, big wet towels that you can get from a pack that you can use, almost like a sponge bath every day, that can be perfectly appropriate. And then giving choices, not just saying, once you get out of the shower, what do you want to wear? You can say, do you want to wear the green shirt or the blue shirt? That can certainly be helpful, trying to reduce their decision fatigue. Also, if someone is resistant to getting the shower, getting in the bath, sometimes getting your foot in the door by saying, okay, we're going to wash your hands first. Okay, great. Now we're going to wash your face. Didn't that feel good? Okay, great. Now let's keep it moving. Let's proceed on from there. Kind of like Chris said, having a big towel that you can use to help them maintain their dignity and help them maintain comfort and privacy, but also helping them do the hand-on-hand technique. So if there's somebody that we would if you can help them with their washing, you're saying, okay, let's help maintain independence and help direct if they need to. Anything you can do to help them maintain their sense of independence as well.
And just sometimes expect the resistance. I've been through this with my own mother, and every time she'd say, nope, I just had one bath. I just had a shower. Don't make me do that today. And, maybe say, you know what, maybe, okay, if you don't want to do it right now, maybe in 15 minutes. But every time without fail, when she got in that shower and that warm water was hitting her, she'd say, oh, I could sit here all day. So I kind of knew that this wasn't going to be something harmful for her. So it made it easier to sort of do that, a little bit of that gentle push. That is just something to keep in mind. And like you said, like Tom said, let them sometimes even put your hand on their hand if they need a little bit of help. And so it's like they're still doing it and you're just guiding them to wash, and tell them every single thing you're going to do, just like you said. So, and I wanted to point out that on our website, in our Take Charge library, under managing activities of daily living, the bathing tips are included in that. So it's always there if you want to refer. And does anybody want to add anything to that they've tried at home that's been helpful? Cody, I can't tell if someone's raising their hand. Okay. Sorry for the interruption. I think we're getting some major deliveries. Here comes Cody. I can't. I just asked if anyone had anything they wanted to share that has worked for them.
Sorry, guys, we had Santa Claus, or in other words, Amazon, show up to our door, so we had to see. But does anyone want to add anything around hygiene? Yeah, Jane, go ahead.
So it's my mom, and we shower about 3 days a week if we're having a good day on a shower day. But on non-shower days, I have found really it's just her bathroom area that needs a little refreshing. So I have a quart-sized measuring cup underneath the sink right by the toilet. And I put warm water in it. And I say, Mom, we're just going to have a little bidet to get the day started because it's not a shower day. And so we pour it. She opens her legs and I just pour the water on her, and and so it's warm water and it's cleansing. And then I give her a clean washcloth to dry, and then she puts it in the hamper. And then we just use panty liners for the daytime, and then at night put a fresh one in. But that really helps because that's really the only thing she doesn't have any odor or anything like that. But I feel like the bathroom area is where I want to make sure she's clean. So that's just been an easy way, but a bidet makes sense to her and it's easy. You got to have the temperature right.
That's a great strategy. Thank you.
And I also think it's a great segue, unless Dr. Chaconas wanted to add anything.
Just real quick, from the neurologic standpoint, it may be helpful to anticipate some of the neurological challenges that dementia can impose upon the individual that might make the bathing process more challenging, like visual spatial awareness, just navigating, getting in and out of the shower, praxis, which is affected, apraxia, which is the medical term for being befuddled on how to do things, even though you have the strength to do it. Just like taking a step into the shower that may be difficult to do. It may affect sequencing, like taking a shampoo bottle, opening it, putting shampoo in your hand, putting it in your hair. So these are all expected challenges that eventually show up in everyone with dementia as it advances. And being aware of that, you may have to provide more assistance, and it helps to just understand what's happening. So on doctors and PA, nurse practitioner visits to our office, if you have questions about the neurological exam that we do on those visits, that may be helpful to discuss.
Yeah, that was great, Dr. Chaconas. Thank you so much for that. And kind of going back to a little earlier, this segues into our next topic, which is big around incontinence. And so I know, Chris, you wanted to talk about that. The question.
No.
Oh, no.
No.
Okay, no, whoever.
Anything special in that.
Oh, okay, that's fine. So Dr. Chaconas or Tom can take this one. But the question around incontinence was, what are some practical ways to manage incontinence at home, especially overnight? So what does that look like, Tom or Dr. Chaconas, if you'd like to take that?
I'll start with that one if you don't mind, Dr. Chaconas.
Sure.
We talk about this a lot. I'm primarily with our movement side of the house, but plenty of folks with movement disorders also have significant memory components as well. And in any of the conditions we treat, incontinence and sleep hygiene is certainly a big factor. Something that we talk about at almost any visit is sleep hygiene, and that directly relates to nighttime incontinence. When I say sleep hygiene, I think it's easy to think about taking a shower, being clean before you go to bed, and that's what it sounds like. But really, it's talking about the practices that help ensure that you get a nice, restful, restorative night of sleep. And then that also helps your caregivers get that same restorative sleep as well. And one of the primary things that wakes people up at night naturally is the need to go to the bathroom. Going to the bathroom in the middle of the night presents a host of challenges, not the least of which is fall risks. And so if we're the first thing I would say is before we go to bed, make sure that the path to the bathroom is free of clutter. Make sure that there's a nightlight in the bathroom. Make sure that if they wear reading glasses or just normal glasses, that they're nearby so that they can put them on if they need to. If they use an assisted device like a walker, make sure that's nearby. If it's a long way to the bathroom, consider having a bedside commode that you can just empty the next day. Anything we can do to prevent falls is generally the first thing that we would want to do. To limit how often you have to get up and use the bathroom in the night, we really get into sleep hygiene. One of the things we push a lot here is helping our loved ones stay hydrated. Typically, our general guidance is 64 ounces of water a day, which is a lot. And it's especially a lot when you consider that needs to generally be before dinner time or including dinner time, but not after. The only time you should be drinking anything after dinner time is if you need to take medicine before bed. So it should just be a few sips to help wash down your medicine. And the big reason for that is because if you drink water after bed, you're almost certainly going to have to use the bathroom before morning. And so if you're drinking a lot of water, then that's just going to increase the amount of times you're going to wake up and go to the bathroom in the middle of the night. So that's a big part of our sleep hygiene. I would say that for avoiding incontinence issues during the daytime, I would say the number one recommendation I can give is timed voiding. So setting a schedule for when you need to go to the bathroom. Even if your loved one says they don't need to go or feels like they don't need to go, by just making it so that every 90 minutes, every 2 hours, you have an alarm that goes off on your phone, or you have the music comes on in your house. If you've got your Alexa device set up to play music and have it on the soundtrack they like, they know, all right, when they hear this song, when Rod Stewart comes on, it's time to go play. It's time to go to the bathroom, right? So that's certainly some options there.
Okay. Dr. Chaconas, did you like to add anything to that?
Yeah, thanks, Tom. I was thinking as you were saying all that, it occurred to me that many times we take incontinence for granted with dementia. I think as dementia progresses, there's a central, meaning a brain cause of incontinence. We have neurologic centers in our brain that control our bladder function. And as those weaken, that sort of bladder control that we take for granted becomes weaker. So we have to rely more and more on our voluntary muscle sphincter to hold the urine in, instead of walking around taking it for granted that we won't be incontinent. We all of a sudden are at risk at any time, and we have to make a conscientious effort to hold the urine as we rush to the bathroom. And that obviously can fail during the day and fails especially while we're asleep. So while if we guessed that incontinence was the direct result or consequence of dementia, we'd likely be correct many times, but there could be anatomical or medical reasons for incontinence that should be evaluated and hopefully would have been evaluated by primary care doctors. We're certainly aware of the causes. Like in men, it could be an enlarged prostate that keeps us from effectively completely emptying our bladder. Some people have what we call bladder atony or an atonic bladder where it stores urine well, but it fails to squeeze down and empty fully. So we always have some residual urine that we could lose in an incontinence situation. And some people have an overactive bladder that fails to store because the muscle of the bladder wall is constantly trying to constrict and force the urine out. And certainly infectious etiologies of incontinence are common as well, where there's irritability of the bladder or the urethra. So we should be looking also for medical and anatomical reasons that might contribute to incontinence in the overall management of that particular challenge.
Good. I know we talked about how to kind of prevent, but let's say these accidents happen. Is there strategies that you guys know that could help caregivers if someone couldn't clean themselves?
Right. So I think that's probably that question that was asked is the nighttime incontinence, because so many of our care partners spend a lot of their time and energy stripping the bed every day and washing the sheets and all of that. And it can be tiring. So of course I know people that have done everything. They've got the plastic or the barrier sheet. They've got underneath everything to protect the mattress. They pad the bed. They have the overnight depends and do everything. And it can still be a bit of a problem, but those are all. And then I think, what Tom said is that maybe limiting the liquids after dinner time would probably be a help, I would think. And Dr. Chaconas, I don't know, I know there's something out called a PureWick that now can be used at home. I don't know if any of our patients have been using that or if they've tried it or not.
Yeah, I'm not aware of that.
You're not aware. Okay. Yeah, I think it's kind
I've heard from Megan that they use that in like the hospital
they
setting.
do, and I've just heard recently that people are able to get them for home use, and instead of like it's just electrically operated. So it's like a wicking material, and I heard they have them for men now too. That it's like an external catheter almost, where it gets all the urine goes into a container that comes out. It's
kind of suction, right? Isn't it?
Right.
Suction
It's like a very low suction.
Yeah.
Yeah. So I don't know. I've just now started hearing about that. So.
Okay. Great.
Oh, and I want to add too, there is another part on our Take Charge Live with all information sheet and a lot of the points that were discussed. It's under all of the safety and strategies. So there is a whole thing on incontinence in older adults. So anyone at home can find that. And if anyone here wants copies of any of this, I'm happy to make them for you before you go.
Perfect.
Let me add one thing. I'm kind of an older doctor. I remember these these pads called Chuck's pads, CHUX, in the hospital. One side's plastic, one side is absorbent. And one of my family members said they were going broke buying them. And everyone said, well, go to Costco, get bulk and all that. So I went on Amazon and saw that there are absorbent but washable pads. I'd never heard of that before. I thought everything was disposable. So that might be something to look at on Amazon. They're kind of big enough to put underneath the appropriate area of our body while we're sleeping to collect urine if we're incontinent in bed, and we can wash them and reuse them. So that could save some money.
That's a good point.
And Melanie actually just dropped the Take Charge link in the chat. If anyone was curious on the website where you can find that around incontinence, Melanie, who is our marketing person, who I knew you guys are all very familiar with her. She's on this call. She just dropped that in the chat for us. So thank you, Melanie. Kind of segueing into our next topic is around handling inappropriate behaviors. So we know that especially when it comes to cognitive change, and that could be for people who have Alzheimer's, dementia, or Parkinson's, right? So that can be kind of dependent on different situations. So Tom, could you answer this question for us? So how can I handle inappropriate behaviors from a loved one with cognitive changes?
Sure. I think it's really important, something that Dr. Chaconas alluded to, was to try to determine if this is an acute change, if it's happened all of a sudden. Most of the conditions that we treat don't change suddenly. You can usually tell a slow kind of, not necessarily linear, but a path that if there's an acute change, we need to try to figure out what's causing it. So if it's the number one thing that we really get concerned about is a urinary tract infection. But then plenty of our medications, especially the antidepressants that are so common in our patient class, can also cause your sodium to get too low. And so if you're ever concerned that, my loved one just really all of a sudden is acting inappropriately, and inappropriate can mean a lot of things. It can be more aggressive. They can get more confused or say inappropriate things. They can do inappropriate things, whether it's inappropriate sexual advances, or sometimes if they're in public and taking off clothing that they shouldn't, that would not be appropriate at the time. Usually that is an indicator of an unmet need of some sort. It may be that they're feeling confused. It could be that they're feeling uncomfortable. It could be that they are constipated, or they have a urinary tract infection and can't get comfortable. So reach out to either our clinic or to their primary care provider to try to get some blood work. It's certainly appropriate. Commonly, we would check a urine level, and depending on what their medical history is, that will help guide what we'll investigate. I won't get into the specifics of things we look for, but anytime we get an email or a call from a family member saying that our loved one just is suddenly much worse, what happened over the past day or two that they changed? Is this the progression of Parkinson's? Is this the progression of dementia? Well, let's investigate why first. But okay, let's say that that doesn't do a whole lot to help us in the right now, right? Now we can try to look for that, but it might take a day or two before we come up with a reason. I'll broach some of the I would say first things that we want to make sure everybody's safe. And just because somebody has dementia or has Parkinson's disease doesn't mean that they're frail. Some people are big and their caregivers are smaller, and we need to make sure that if someone's being aggressive, that they get help first. So part of that is making sure that you have a plan of who you're going to call if you need help, right? And it's easy to make that plan when you're not stressed out. So when the sky's blue and everything's good is when you need to make that plan. Could be a neighbor, could be a loved one who doesn't live too far, but somebody who you can call to get some help. Obviously we prefer to limit 911 use, but if you need to use it, by all means, give them a call. I mentioned that trying to identify triggers, so trying to identify if somebody's uncomfortable, if their bladder's full, if they're constipated, if they're just bored and need some additional stimulation. trying to make sure that our loved ones get the social stimulation, the intellectual stimulation that they crave, can certainly help with these things too. Last two things is redirecting. So sometimes saying that, if they're being either aggressive or maybe sexually inappropriate, helping distract them with something else, something that that they enjoy doing, something that they've been asking about, can certainly help redirect and buy you some time. And then the last point I wanted to make was trying to a certain extent, empathize. So instead of just if someone says something that you feel like is inappropriate, for example, if they say, I hate you, no one wants to hear that, right? But instead of fighting back at that, saying, it sounds like you're really frustrated right now. Maybe we can talk about that once we calm down.
Yeah, that's good. Mm-hmm. Anybody else want to add anything to that?
Yeah, I would say that in our management of dementia, we're not only looking at cognitive abilities and the burden on a person's brain as dementia progresses, and we lose cognitive functions that translate into more dependence and greater care needs. We also look at what we call neuropsychological behaviors. So the word neuropsychological is a distinction from purely psychological. When you hear the word neuro in front of psychological, it means the psychological behaviors that are adverse or derived from an illness in the brain, namely the dementia. But they're very similar to primary psychological conditions. And the most common we see in dementia include apathy, anxiety, and depression. And in more severe forms, we'll see psychosis, which includes visual and auditory hallucinations and delusions, often paranoia. And by definition, delusions are fixed false beliefs that we can't change in a person's mind, no matter how much evidence to the contrary we present to refute their belief. So knowing that people with dementia can get a whole host of neuropsychological symptoms, as long as we're on the alert and ready for them, we can reason through it and know that the person who's angry, potentially violent, potentially paranoid, this is a consequence of the dementia and not something lacking in our care for them. And to Tom's point, looking for internal, meaning inside their body, triggers, like anything that causes discomforts is important. Sometimes it is environmental, where there's too much chaos. There's the paranoia can trigger a worry when there's a room that's ill lit, and there's a darkness that they look into and wonder what might be in the other room, for example, or outside a window. So, all of the non-pharmacological techniques of trying to manage that kind of behavior are important, many that Tom alluded to. But sometimes, no matter what you do, there's such a prevalence of this behavior that you're calling on us to help with pharmacotherapy, with medications. And we're very careful that we're not seeking to drug or sedate our patients for a whole host of reasons. It's not fair, not a great quality of life. They tend to be off balance and fall. They can't enjoy life to its fullest when they're under such an influence or burden. So we're always trying to minimize medications and use first-line medicines that tend to be the most safe and tolerable. And many of you may be aware that in our clinic, we have access to a genetic test where we swab the inside of a person's cheek, and we can get a list of medications that are for psychological symptoms that are tailored to that person on a genetic basis, where they're more likely to work and have a lower rate of side effects. But often it takes a combination of pharmacological and non-pharmacological techniques to help people with these adverse behaviors.
Thank you, Dr. Chaconas, on that. Yeah, that was really good. I think one of the last big topics before we open the floor is one of the biggest things that we hear a lot in the clinic is around transitions, right? And how we transition. How do we know when it's time for someone to maybe move out of their private home into an independent living or an assisted memory care unit? So the big question kind of circulating is, when do we know it's time, or how do we know if there is a time for that? And what do we do when that happens? So whoever would like to take that away.
Well, I think that's something that's very situational dependent. People can be in their homes if they have people coming in to help and support them, for a long time. I think that if they are wandering, or if they are no longer able to know how to react in the situation of an emergency, are two big things that can happen that can change that. So a lot of times it does boil down to that. And also sometimes it's just a lot to manage, and maybe their loved ones at home have done this for many, many years. And maybe they have their own health issues now, or something else happens, and they're just not able to continue it anymore too. So that's another situational thing that we see often. Tom, do you have anything?
Yeah, I think it's easy to kind of say that that it's always based off safety, right? It's if they can't be safe in the home, then it's time to consider an assisted living facility or skilled nursing. And while that's certainly true, I don't want people to think that that's the only time. Dr. Chaconas mentioned that we're really looking for quality of life as well. And we're huge on the socialization aspect. Depending on the family situation, if maybe a patient, maybe your loved one is safe, but they're sitting at home watching 10 hours of television a day, and maybe they're not have to have the TV turned way up because they're struggling with their hearing, right? And all these factors that we know are likely not contributing to them having the best quality of life. If it's feasible to have them into an assisted living facility where they can have more of a social life with the other residents, especially if it's a facility that provides these enrichment opportunities, then that would certainly be a time to think about assisted living. Also, I mentioned safety, but it's not just immediate safety, it's the caregiver's health. There are plenty of times that we see caregivers who are they love their loved one, but they are sacrificing their health and well-being to make sure that their loved one is taken care of. And that's only sustainable for so long. There can certainly get to a point where caregivers are not able to manage the medical needs of their loved one. I like to say that even if the loved one has a medical background, they're a family member and a loved one first. We don't want to get to a situation where the relationship becomes purely medical, purely transactional. To help manage that relationship, sometimes it can be helpful to transition into assisted living. I will say that it's not always one or the other, though. There can be, we have an excellent family care family care navigators. One, but another, some people else, others who help. But our family care navigator is excellent at knowing the different resources in the area, knowing about adult daycares and other enrichment activities that they can do, so that to help give you some respite during the day.
Good.
The only thing I would add, something I failed at with my family, but I learned from our families in this practice. Many of the people who make the decision in a timely way, in other words, they didn't fall on the sword and sacrifice themselves, too inordinately long, if it was appropriate to eventually transition their loved one to assisted living or memory care. These were the folks that planned in advance. So it's never too soon to investigate choices, to get on waiting lists, to tour, to understand what's out there, to give you some perspective as the years go on, to see what the options are. And a lot of us, when we're in the dark, we haven't planned and visited different places, we may have an inherent distrust. I mean, who can take better care of our family members than ourselves? I mean, we certainly have to, generate or instill trust in the individuals that we're allowing to take care of our loved ones, and witnessing how that works firsthand is important with advanced planning, even if it's in years in advance of moving somebody. But, when I first came to Charlotte, I think it was 1998, we didn't have all the choices we have now. Also, the wait wasn't as long. So putting down a nominal deposit that's refundable to just have a place card. So if the time comes, you have the opportunity to move on that. That's important now, since we're all getting older and we're all taking more and more advantage of the resources in our community. So just plan ahead, even if you're not ready to pull the trigger on the plan.
Yeah, and you guys may have seen last month we had the family care navigator, a new family care navigator, Margaret, who was a part of our last conversation. And I always hear her say the one thing that she recommends, especially around these assisted living, independent living facilities, is to show up unannounced, because they can't prepare for you, right? So you get to see actually what the operations look like if you show up and you say, hey, I would like a tour. So they don't have time to, maybe clean up an area, make it smell nice, so you can really just get the authentic experience of seeing what these facilities look like. And so they might not be able to tour you in that moment, right? But they can schedule you, but at least you get a good sense of what that feels like when you come in the door. But without further ado, I do want to open it up for the remainder of the time that we have for any questions from our amazing audience. So if you, once again, would like to come off mute if you are on Zoom, you can throw it in the chat, you can come off mute, and then we can go from there and see what comes out.
I want to make one more point about different facilities, whether that's independent living, skilled nursing, or assisted living. If you know a firefighter or an EMS professional who you love and trust, you can ask them their opinion, because I'm sure they have been to every facility in their district.
That's a good point.
And they see the behind the scenes of what really happens there.
That's a good point.
That's really good.
Yeah. So does anybody have any questions for us?
If not, I think there were some questions about communication.
Yeah. If we
Is there anything coming in?
Let's see.
Okay.
Don't be shy. If not, we have a couple more that were pre-sent to us, but just want to give anybody the opportunity that wants to speak. Well, if you're still getting to that unmute button, then we do have one more question, is around how about having a conversation with somebody. I know sometimes that conversation pattern can change. And so what does that look like, or what are some strategies that you have around having a successful conversation with someone with dementia or with cognitive change?
Yeah. And it can be very difficult, because you find yourself the give and take. Maybe you've been married for many, many years, and you have your established patterns of communication, and now all of a sudden that's gone, and it can feel lonely, and that person has changed, but they're still human, and it's up to us, I think, to find and meet them where they are, and to find that connection. What can you bring up? What can you connect them with? Something that they did in their life that they enjoyed, or their accomplishments. Try to avoid saying, do you remember? And instead say something like, I was thinking about, and then you can bring up the topic. So it is very difficult. Sometimes you have to do more of the talking, or sometimes, don't feel like you have to talk all the time either. Sometimes just your presence taking their hand, just sitting together is just fine. Because sometimes their words, it becomes difficult. They have difficulty with finding the words or coming up with the response that they want to say. It just doesn't come out. So, a lot of patience, and then just a lot of recognizing that they're still in there. And it's just a matter of really digging deep and trying to find them.
Chris, what you just mentioned with Joanne. Now, Joanne was one of Dr. Edwards' first patients when he was down in Randolph Road and everything. And Joanne has passed 10 years now. But I just chuckled when she said, about remembering. With Joanne, my kids would say, or somebody would say, don't you remember? And that was a kiss of death with Joe. I mean, she just went bonkers. And I had to bite my tongue. I don't know how many times, whatever, it just,
It is. It's a different pattern. You just kind of have to, and I heard someone speak and they said, it's kind of like a tree in different seasons. It's the same tree, just looks a little bit different, presents a little bit different, but you can still find them. Yeah. And then your tone, and you, and there's a whole host of, we do have another communication do's and don'ts too in the library as well. You have to use like a lot of positive language. You don't want to all of a sudden become the person who knows everything and, maybe always directing them. It's just kind of really stepping back and kind of, thinking about how you're coming across, because it's probably not always going to be taken as it used to be, your comments and things like that. Anybody else?
Did anybody else just want to add anything there, Dr. Chaconas, Tom, before we move to that other question that's dropped in the chat?
Sure, real quick, from the neurologic standpoint, when we think of communication, we think of speaking and understanding the spoken word. But just like memory can decline, our language can decline. And we all know that we can start searching for words. And we may lose fluency. We really struggle to say what we want to say. And many times we'll retain an internal monologue in our brain, but just not be able to say exactly what we want to say. And over time, that internal monologue can become fraught with error as well. So you can imagine as a person's language declines, they may speak less, they may understand less. So they can misunderstand quite a bit as well. So it would be important that when you're communicating with someone with dementia, you're speaking directly to them. There isn't a lot of other people talking at the same time. You might have to repeat yourself and repeat it exactly the same way. Just to make sure they really understand what you're saying. And I've fallen into that trap in the exam room where a patient will leave believing I said exactly the opposite of what I said. That happens quite a bit. So be aware that over time, verbal processing, the ability to understand the spoken word, can be fragile. And you'll have to verify that they understood you after all.
Yeah, Melanie just actually threw in the chat that she heard a story last week about using music and music. Music. And we've actually had another Take Charge Live previously about music therapy and how important that is, or music just in general in everyday life and how it brings memories back to people. But that's what she just talked about, is that, a caregiver had shared that he plays music each day that she always had liked, and then they'll dance, and it brings her kind of back into the moment, which is that's a great strategy as well. One other question that got put into the chat. The question reads, my mother will have bowel movements and just want to wipe once. Any tips on getting her to be able to wipe more?
So as Dr. Chaconas said, a lot of times the sequencing of anything, and it can just be that. It can even be, getting the toilet paper, wiping, and then putting it, sometimes they want to put it in the trash, or it just gets kind of mixed up. That's probably where I would say they're going to need a little bit of assistance in the bathroom, and just gently, you know what, that you did a great job. I have this warm wipe, is it okay if we just kind of go over one more time, and that kind of thing? Because a lot of times you're right. And it's not, from a hygiene standpoint, it's not okay to just let that go. So it is something to monitor, and possibly kind of have to step in and assist with that.
Yeah, there was a further comment because Melanie had said there's an option to use a bidet. And she actually responded back and said they have a bidet, but it doesn't help as much as they would want it. So just kind of that feedback.
Mm-hmm.
Yeah, leaving, love whiteboards, love signs, but they're not always, they as long as they work, great. But if they lose their utility, then obviously it's the hygiene and safety aspect that may require more direct approach.
Mm-hmm. Okay, great. Any other questions you can put in the chat from anybody?
I have a question.
Yeah.
I try to not be naggy, and reminding, have you taken your morning pills? Have you taken midday pills? Are there other ways besides just always asking, did you do this? Did you do that?
Sometimes,
I'll repeat the question for people online too.
Okay.
So we did get a question from someone in person talking sort of, and you can correct me, about medication management. And so the idea that, okay, so they have the morning meds, they have their afternoon meds, but is there a way that can improve the medication management without having to continuously ask them, have you taken the medicine?
So when you ask, and does he say not yet?
Yeah.
Okay, not yet. And then you have to ask again. I'm not sure. Okay. So one way would be, even if you don't take medicines, maybe you take a vitamin or something. So it is whatever time it is in the morning. It's 9:00. I just got a ding. I got a reminder. It's time for us to take our medicines, and then do it together. And we're not going to wait. This is important. We do this now so we don't forget. With my mom, she didn't want to drink water, so I had to come up with we would play a game, or we would talk and look at something, and all of a sudden, if we both got say cheers, we had to take a sip. So I've made games out of things. And then a lot of times, just doing it together, because maybe in your mind you think, well, he's got the medicines and they're out here, and I've given him a reminder, and then just coming to the realization that maybe that worked for a while. But if you're having to remind, it's probably time to say, okay, it's just time to do it now. And then how do you think you'd respond to that?
Sometimes it's okay, but if I have to do it every single day, 3 times a day, it just I feel badly about it too.
Right.
Because I don't want to have to constantly remind him about that. And he does have a tendency to want to put things off. Okay, I'll do it later. I'll do it. Just. I feel so much better if we could just do this now, and then we know it's done. And maybe you have an alarm or something go off, so it's not you being the reminder. It's the tone, it's the little ding, and then you could say, "Oh, this went off," and we can't wait too much longer. It's going to be time to take them again in the evening, right?
Maybe not M&Ms, but other piece kind of candy that looks kind of like a medication. That can be your medicine that you need to take. All right, it's time that we're going to go take our medicine, and that might be Mike and Ike's for you.
There you go. There's right there.
There you go. And then it gets to be that anytime he needs to take his medicine, well, time for you to get your little treat that's also your medicine. All right, time to take our medicine. Let's make it a team effort.
Let's see. There was another suggestion in the chat talking about teeth brushing.
Okay.
So that's a great one. So just a strategy that somebody has said, that's something that has helped with teeth brushing is after my mom brushes her teeth and leaves the bathroom, I put toothpaste on it again and set it by the sink. The next time she uses the bathroom, she sees it and brushes. So that's just, building habit building, right? And so every time you see it, that's a really good strategy. So thank you for putting that in the chat there.
That's really good. Yeah. And then just getting them, maybe even if they don't want to brush their teeth with every meal, just to rinse their mouth with some water can help. Trying to get them to their cleanings, their dental appointments, which is sometimes not easy either. And then sometimes mirroring too. I'm going to brush my teeth, same thing, and then they'll do theirs at the same time.
I think with these type of heavy questions, I think I want to leave us on kind of just this idea around kind of what we started with, this idea of like, people may not be able to do everything, right? But is there some final words that you would leave to kind of encourage our caregivers, our patients who may be on this call around just encouraging them to do this? Yeah.
I mean, it can be a long day. And the thing is if you get through, we got the shower done today and we got the teeth brushed and everything else. But guess what? In a 3-4 more days, you have to do it, you have to go through it again. And so it can feel a little, but our 4 tenets of care are calm, clean, safe, and loved. So what you're doing, the work you're doing is absolutely important. A person can just feel so much better when they get a shower. I think that's common with everybody. And you're helping them be clean. You're helping them be safe by sort of monitoring and helping to prevent a fall. Calm with your calmness. Hopefully that'll carry over and they'll be a little bit calmer. And then loved, because I know you're doing all this with great love and they feel it. So I applaud all of you. Every one of you.
I have a few final closing thoughts as well. We haven't talked about it, but sometimes family members or other people will try to tell you what to do and try to how to manage your loved one. And in that case, you can ask them to do something for you. They say, okay, great. Well, you can be the one who picks up groceries on Tuesday. And if they say yes, then suddenly you've got some help. And if they don't respond, well, they're not going to bother you again, most likely. So asking directly for help is to be a good idea. Also, just from my mental health background, I will say that it can get to a point where there can be some resentment that people can feel towards their loved ones because it's a big change to their life, but it obviously affects your life as well. One way that I would try to frame this is that your loved one is ill. It's not that they are, they're not, they don't want to be the way that they are. They're not, it's not that they are intentionally making things difficult or intentionally acting in inappropriate ways. It's that their brain fundamentally works differently than it used to. And acknowledging that you're doing all you can to help with that, but also that that you have to try to meet them where they are, can certainly help frame your point of view. And also, I think there's the phrase gets used a little bit too much these days, but you can't pour from an empty cup, right? So you got to try to take care of yourself. Easier said than done sometimes, I know.
Yeah.
One thing too, as everybody, you guys are talking and everything, and I just remembered with my children, who were not little kids at the time when Joanne went into assisted living and so forth, and I was a full-time caregiver for like 5 years before that happened, and my kids wanted to have a meeting, so we had a meeting. And they started out very point blank. Well, Dad, we decided you keep this up, you're going to die before Mom. You can't do everything, whatever. She needs help above and beyond where you're at and what you can do for her and everything. And if you continue doing this, you've already had one heart attack. You don't want to have another one. So just chill out and listen to your kids for a change. Because we listened to you for all those years to do whatever they said, and so that's how. But then the important thing that you also mentioned was I mean, just happened to boom like this, and Connie had to go out and start looking for places and everything else. So, telling people to go out and look beforehand and checking places out, checking out histories on them, what you can do on Google and this and that to check out XYZ corporate cover owns this place and this and that. Very important.
Yeah. Dr. Chaconas, did you have any closing thoughts?
Oh, thanks. I do. Somewhat personal. And we all learn from our families in this practice and what they've done and then our own personal experience. And I've come to the conclusion that, we're in the business of managing incurable diseases, currently dementia. And I certainly have high hopes that it's not going to be incurable for much longer. But knowing what we know now, we all want to do the best job we can. And a word of advice I got from the wife of one of my patients is, if you're a caregiver, start the day with a prayer for strength and end the day with a prayer of forgiveness for what we might perceive as failures along the way. And then the other thing I concluded in my practice is that as people progress in dementia, their world becomes more and more constricted. It shouldn't be isolating, but it becomes more simplified in many ways just by virtue of our loss of capacity to self-direct our own entertainment and our own ambitions. And the individual that's in that constricting life often is far better off than the people witnessing it. We look into that world and we lament the changes we're seeing. But the individual with dementia, as long as they're well cared for and feel safe and comfortable and dignified and have ample opportunities for joy in their life, which often is being amongst family and friends, they're doing pretty well. And one of the best examples of someone who looked into that change and dealt with it well was my daughter. So her grandfather was declining with dementia, and she never treated him any differently. She was unfazed by it. It might have been the naivete of being a little girl, but it was quite instructive for me.
Yeah,
that's very good. Very nice.
Well, that concludes our March Take Charge Live. Thank you so much for everyone's attendance. We know that this is such an important conversation. We know that this doesn't end here, but always feel, you may have questions that you didn't feel maybe comfortable coming off of mute or putting in the chat. Just know that we're always here as a resource for every single one of you. Okay. Stay safe, stay confident, and we're here for you. Have a great rest of your day. Bye-bye.
Bye-bye.
Thank
You're
you.
welcome. Thank you.
Thanks, everybody.
Thanks, Cody.
Thank you.